Normal basic wrist X-ray series approach. The basic wrist series is comprised of a posterior, oblique, and lateral projection. The series examines the carpal bones that are consisting of the scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate and hamate. It also examines the radiocarpal and distal radioulnar joint along with the distal radius and ulna. Indications of wrist X-rays are including wrist trauma, suspected fracture, obvious deformity, bony tenderness, non-traumatic deformity, non-traumatic wrist pain, normal anatomy of the posterior anterior wrist radiograph. Distal radial articular surface tilts 17 degrees towards the ulna. Medially the radius articulates with the head of the ulna at the ulnar notch. The head of the ulna is normally up to 2 mm shorter than the radius, and either touches or slightly overlaps the radius at the distal radioulnar joint. The width of the intercarpal joints is uniform, approximately 2 mm. 3 carpal arcs should be traced. Along the proximal row of carpal bones, proximal aspect. Along the proximal row of carpal bones, distal aspect. Along the capitate and hamate proximally. These 3 lines should remain unbroken. The distal radial epiphyseal line may remain as a linear density, with a spur-like projection laterally, simulating a fracture due to the break in the cortex. However, this is a normal variant. Normal anatomy lateral wrist radiograph. The distal articular surface is angled 10 to 15 degrees anteriorly. This is useful when identifying subtle fractures at the distal radius with flattening of this angle. Articular surfaces of radius, lunate and capitate should be in a straight line and be congruent parallel. The apple capitate should sit in the cup, lunate, which should sit in the saucer radius. Common pathology. Colles fracture, the most common distal radial fracture in any adult group. Peak incidence in elderly women. Usually, following a fall onto an outstretched hand. Dorsal angulation of the distal fracture component. Important to determine if there is intra-articular extension. Smith fracture. Account for less than 3% of forearm fractures. More common in young males and elderly females. Fall onto flexed wrist or direct blowback of wrist. Classically, an extra-articular distal radius fracture with palmar angulation of distal fracture fragment. Also called the reverse Colles fracture. Scaphoid fracture. 80% of all carpal bone fractures, usually young adults, fall on an outstretched hand. 80% of fractures are through the waist of the scaphoid. If suspected, perform additional scaphoid views. May be radiographically occult. Should be followed up if pain persists. Triquetral fracture, second most common carpal bone fracture. Hyperextension or avulsive injury, frequently seen as dorsal chip fractures on lateral views only. Perilunate dislocation, typically occur in young adults. Following a fall on the dorsiflexed wrist. Best detected on lateral view. The lunate articulates with distal radius but capitate does not sit in lunate, cup. 60% associated with scaphoid fracture. Don't miss. Scapholunate dissociation. Injury to the scapholunate and radiolunate ligament results in scapholunate dissociation and significant instability. The scapholunate space is widened, greater than 4 mm, the Terry-Thomas sign. Lunate dislocation. Much less common than perilunate dislocation. Commonly occur in young adults. Fall onto a dorsiflexed wrist. Carpometacarpal dislocation. Rare but important injury to dominant hands of younger males. Younger male predominance. Often occur after a punch followed by a fall. Reduction of joint space on the anteroposterior.